Okay, it is 12 o'clock, so we're going to get started so we don't run out of time today. Hello, everyone, and welcome to this month's Northwest ATTC webinar. I'm Meg Bruner, and I'm your host for today. We're very excited to have Dr. Honora Englander here from OHSU to talk to us about team-based addictions care in general hospitals. Let's see. Figure out how to move the slide. Here we go. Hello. Okay. Before we get started, I just want to let everyone know that here at the ATTC, we believe that language matters and words have power. We strive to be culturally informed and inclusive, and we really value your feedback on how we're doing with that. Please email us at northwest@attcnetwork.org if you have any comments or suggestions. A couple of quick housekeeping things before we get started. First, if you have any questions for Dr. Englander during the presentation, please type them into the chat box at any time. After she's done speaking, I'll be reading the questions to her so she can answer them for us. You'll also be getting an email at the end of today's webinar that has a link to a survey in it. Please take that survey. It'll help us make sure we're bringing you the quality content you crave. That email will also have a link to download the slides from today and a link to our website where you'll be able to find a recording of the webinar later this afternoon. Additionally, we'll be sending everyone who attends this live webinar a certificate of attendance in about a week. You don't need to do anything to get the certificate unless you're watching this with the group today. In that case, please have someone in your group email us within 1 business day all the names and email addresses for everyone in the group who wants a certificate. Again, our email is northwest@attcnetwork.org. Okay, on to the webinar. Today's speaker is Dr. Honora Englander. Dr. Englander is Associate Professor at the Department of Medicine at Oregon Health and Science University. She's also the founder and principal investigator of the Improving Addiction Care team, and her focus is on changing the standard of care for hospitalized adults with substance use disorder by redesigning care and shifting our view of addiction from one of shame and stigma to one that embraces belonging, treatment, and healing. Dr. Englander has received a number of very cool awards, including being named one of Portland Business Journal's top 40 under 40 in 2015 and one of the American College of Physicians Hospitalist Top Docs in 2012. So welcome, Dr. Englander. We're really excited to have you here with us today. I'm going to transfer the slides to you.
Yep, can you hear me okay?
Yep.
Terrific. Thank you so much. My name's Honora Englander. Thanks for the kind introduction, and thanks to everybody for being on the webinar and for the folks at ATTC for inviting me and putting together such a important series. Today I'll be talking about team-based addictions care in general hospitals, and my hope is really to spend the first part of our time giving a talk and then have plenty of time for questions. And just an outline briefly, I just want to start telling you my story and how I came to this work, and really then talk about our story at OHSU, or Oregon Health Science University. And our story at OHSU really is a transformation story around how we as a hospital have approached caring for people with substance use disorders. And I'll talk about the needs assessment and the development of impact, which is our hospital-based addictions team. I'll talk about some of our outcomes from our research studies and implications and lessons learned. But to begin, I want to share a patient story. This is a photograph that some of you may have seen. This is not a patient of mine, but this is a photograph of Madeline Linsemeyer, who is a young woman from Burlington, Vermont, who died at the age of 30. And this is a picture that was posted on her obituary, which is really a very compelling and important, worthwhile read if folks are interested. And in Maddie's obituary, her obituary went viral on social media, and her sister and family who wrote the obituary described her as a young woman who was hilarious, warm, fearless, and resilient. And I share her picture and her story because she reminds me of so many of the people that I've seen and cared for, and really in particular one patient who I met in late 2012. This young woman who I met in the fall of 2012 was in her early 20s. She was hospitalized with endocarditis, which is a life-threatening infection on her heart valve and a consequence of injection drug use. And when I met this young woman, she was really struggling. It was actually her third hospitalization. Over the summer, she had been admitted with endocarditis. She had been started on intravenous antibiotics and had been in hospital care or in skilled nursing facility care for several months. She was initially admitted to get antibiotics, then readmitted and got valve surgery. So she had her chest wall open, she had surgery on her heart valve, and continued on IV antibiotics. And when I met her, the medical reason that she was in the hospital was for chest wall pain. But what was really clear in my caring for her was that she was grieving. She was really struggling with an opioid use disorder. It was unclear to me if she'd had active use, but she was grieving. Her boyfriend had died of an overdose. She was in a lot of pain. And we really didn't have the tools in place in the hospital to care for her. We didn't have policies or practices around giving her methadone to treat her. I don't believe she was in fluoride withdrawal, but we didn't have medication to treat her opioid use disorder in the hospital. And she felt desperate, and I also felt a real sense of desperation in that I wasn't able to connect with her or reach her. And we did our best, and again, we were well-meaning, but I didn't feel like we had the systems in place. And specifically, we didn't have the systems in place to treat her opioid use disorder. So we were not equipped to treat the primary disease, which was the opioid use disorder. And this was a tremendous cost. She'd been hospitalized for several months. And sadly, when I got a page several months later in the winter of 2013, I was not surprised, but really, really saddened to learn that she had died. And so, despite our efforts to support her, we didn't have medication, we didn't have pathways to treatment, and this young woman with so much potential passed. This young woman's story really mirrored what I was seeing more generally, which was that hospitalizations related to opioid use disorder and substance use disorder in general are rising. So I cared for this young woman at the tail end of 2012. And this is a figure that shows rates of opioid-related hospitalizations in general medical hospitals. And there was a 64% cumulative increase from 2005 to 2014. And when we rank order states, and by the states that have the highest rise in hospitalizations related to opioid use disorder, Oregon ranks third, Washington ranks fourth. I know folks are from a variety of places, but given that this is a Northwest Regional Conference, I just wanted to highlight that, that regionally we're seeing this, and hospitals really are getting hit hard. Similarly, if we look at rates of amphetamine-related hospitalizations, similar patterns emerge. So here you can see that again in those years between 2005 and 2014, and the numbers only continue to increase, we're seeing increasing rates of hospitalizations related to amphetamine use disorder. So we know that substance use disorder drives high rates of hospitalizations, also drives readmissions and long hospital lengths of stay. And one thing when I talk to hospital leadership about this that I think is so important to highlight is that this is a tremendous cost. So in 2012, the United States spent $15 billion in inpatient hospital charges related to opioid use disorder alone. And despite this, many people are not engaged in treatment. We know that, and health systems have been slow to respond. So hospitalization often addresses the acute medical illness. And in the case of the patient that I described, this was a woman who had valve surgery. She had months of IV antibiotics, but the systems weren't in place to treat her underlying cause, the addiction. And this leads to significant waste and poor outcomes. And we know that effective treatments exist, but that they're underutilized. So medication for opioid use disorder reduces mortality by half. We know that harm reduction is a really critical component of care. And yet, again, most hospitals across the country and across the region, they're not delivering these evidence-based services and care. So again, thinking back to 2014, 2013, when I was really sort of reflecting on this young woman's care and trying to think about how do we do better and how do we do differently. The first question from a research question was, is hospitalization a reachable moment? Do patients want treatment from who are hospitalized? And if they do they want treatment? Because people are not seeking treatment when they come to the hospital, they're seeking medical care. But if they want treatment, is this a reachable moment? And that really was our first question. And so we performed a qualitative study, and this is one quote from that study that I think is so important, and I share commonly with hospital providers. This is a patient who described, most of us that do it, referring to her opioid use disorder, can't stand it. I hate this stuff. It's wretched. It's like damned if you do, damned if you don't. When I do it, I don't even feel good anymore. Like it takes so much just to be okay, to be normal. It's like when I use, I just feel normal. So they, referring to healthcare providers and in particular in the hospital, don't understand that. So we performed a needs assessment. We surveyed 185 hospitalized adults between September of 2014 and April of 2015. Again, really trying to understand this question of because people aren't seeking treatment when they come to the hospital, is this the right time to intervene? And what we learned is that 57% of people with high-risk alcohol use and 68% of people with high-risk drug use wanted to cut back or quit. And folks told us that they wanted medication for their addiction and that they wanted this medication to start in the hospital. They also explained what we knew somewhat, but understood in much better, much more clearly from patients, which is that there's a gap time to treatment in the community. So if we were going to start medications like methadone or buprenorphine in the hospital, and we were going to tell people they needed to wait 2 weeks to get into a methadone clinic, this was highly problematic. And then patients also told us loud and clear that they valued treatment choice, they didn't want to be pushed into treatment, and that they wanted providers that understood substance use disorder. So given our needs assessment findings, the next question was, what do we do? And also, how do we pay for it? What I didn't mention is that I had been doing work around healthcare transformation, around hospital to home transitions for highly vulnerable folks. This was, again, sort of at the cusp of some Medicaid transformation efforts, but really from the perspective of hospital administrators, not a whole lot was happening in the hospital. And so it was incumbent upon me to develop a business case for any kind of investment. So this is a paper describing how this study that I shared some of the findings from, and describing how we developed IMPACT, which is the Improving Addiction Care Team. And so what we did was we took our findings from our needs assessment and we convened partners from across the metro area and across the region, and folks from Central City Concern, from CODA, which is one of the opioid treatment programs, from Mental Health Association of Oregon, PSU, Care Oregon. We all came together and basically mapped findings from the needs assessment to components of the intervention. And I'm going to walk you through this kind of step by step. So because hospitalization is a reachable moment, and because we lacked expertise to assess, engage, or initiate treatment for substance use disorder, and because trauma and trust were such key issues for patients and key things that we needed to address, we developed an inpatient consult service. And initially our service was comprised of physicians, a social worker, and a peer recovery mentor. I'll never forget Ed Blackburn, who was the executive director at Central City at the time, when we convened that group to review needs assessment findings. Ed said loud and clear, he said, what I'm hearing is there's issues around trust. That makes sense. Hospitalization can be traumatic for people, and you need to have peers. And at OHSU, and in fact in hospitals across the country, certainly at OHSU, we've never had peers as part of the workforce. So this was a really important insight that we got from listening to patients and including the right stakeholders, and has proven to be a very important part of the intervention. Because there were no usual pathways to outpatient addictions care and long community wait times, we developed rapid access pathways to treatment in the community, and we supported those pathways initially with a coordinator role. Over time that's evolved, but again, these pathways to treatment are really critical. And then finally, because patients who needed long-term intravenous antibiotics, they had very long hospital lengths of stay, and community treatment, in particular community addictions treatment, but also community treatment from skilled nursing facilities and other settings where people might get IV antibiotics, were not equipped to manage infection and substance use disorder together. So they might be able to manage substance use disorder or maybe an infection, but people who had combined medical and behavioral health needs really were struggling from the hospital. So because of that, we developed a model called a medically enhanced residential treatment model, where we integrated intravenous antibiotics into CODA residential, which is one of the opioid treatment programs. And that actually was a failed model. I'm not going to spend a lot of time getting into that, but if folks have questions, I'm happy to take those questions. We launched in the summer of 2015. And this is a figure that I want to show about the question of how did we, so that was sort of the model, but I want to show how did we pay for it. And so again, this is a figure from that needs assessment. And what it shows is that substance use disorder is associated with long hospital lengths of stay. And so if I may, I'm just going to walk people through. So on the y-axis, you can see this is the expected hospital length of stay. And in case it's not clear, the length of stay is how long people are hospitalized. From the vantage of hospital administrators, long hospital length of stay is highly problematic because of the way that payment structures work in the hospitals. Hospitals get paid for an episode of care, for a hospitalization, but there's an incentive not to have people in the hospital for longer than they need to be, both because hospitals are so full and then also because of the way the payment structure works. So here on this figure, we've plotted the expected length of stay on the y-axis with the actual length of stay on the x-axis, and each dot or triangle or square represents one person in our study. There actually were a couple people that were really strong outliers, some people who had over 100 days of hospitalization, and we excluded them from this figure. And what you can see, this line here is called the line of identity, and what that means is if the actual and the expected length of stay matched up, what we'd see is all these dots would cluster around that line, and instead, what you can see is that people's actual length of stay exceeded what we would expect for their condition, for their medical condition. And when we then plot folks who had endocarditis, the infection on the heart valve, or osteomyelitis, which is a bone infection in the setting of injection drug use, those folks were really driving these extremely long lengths of stay. And so it was really around these findings and this figure that we were able to build a business case for why there was an opportunity and why it was, again, there was certainly a quality case. And I think an ethical and moral case as to why we should be investing in addictions care in the hospital. But certainly at the time of 2014, 2013, it was really important also to highlight a business case. And I suspect this is still the case. I will say though, with the business case that, in 2013, it's not like you open the paper every day and we're hearing about the epidemic of substance use disorder. So I think culture has changed in that regard too. So what is the effective impact? I'm going to shift gears and talk a little bit about some of our research findings. Since we started, and I should probably update this, I think the number is now closer to 1,600. We've served approximately 1,500 or more medically and socially complex patients who are hospitalized. And when we look at some of the demographics of folks, 60% of people that we work with are experiencing homelessness. 80% have Oregon Medicaid, and there's high rates of polysubstance use. So these are not mutually exclusive categories. About 65% of people we work with have an opioid use disorder, about half have an alcohol use disorder, and about 40% use methamphetamines. And then certainly we also see people who use benzodiazepines, who use numerous other substances. And this is a study that we did looking at the effective impact, our consult service, on post-hospital substance use disorder treatment engagement. What we did was we compared 208 patients who were seen by Impact and who had Oregon Medicaid, and we compared them with similar hospitalized patients who didn't receive Impact, who we used propensity matching, which is some sort of fancy analytic tools in the Oregon Medicaid data to find control patients, similar patients who didn't get Impact. And what we found was that Impact increased community addictions treatment engagement from a baseline of 17% in both groups to 39% in the Impact group in the month after discharge, compared to 23% in controls. And this is an adjusted odds ratio of 2.15. So people's odds of engaging in treatment was over doubled. And we use a fairly rigorous measure of treatment engagement. We use the HEDIS measure, which relies on multiple encounters in the 34 days after discharge. Also somewhat provocative and important, and we have an ongoing study to look at this, was that 1 person in the impact group died compared to 14 in the control group, and certainly this warrants further study. But this study is really important for a number of reasons, which is that treatment engagement is associated with the treatment engagement is somewhat of a intermediate measure, but it's associated with really important long-term measures, including mortality, including reunification with family, including better health, lower costs, all of these things. Also, we've done some qualitative work to look at what is the effective impact in hospital care and providers' experience. And I have to say, this is some of the most surprising and delightful pieces of the work. I wasn't expecting this. I thought when we created Impact, it would be really a patient-level intervention, and what we've seen is that it's a system-level intervention that affects providers. And so this is from a whole bunch of different work, but one of the quotes from a provider was that Impact created a sea change in hospital culture. And what we've seen is that Impact increases provider understanding of addiction and how to treat it. There's a sense that we reduce against medical advice discharges and long hospital stays, and we're doing some further work to really hone in on the numbers here. That we increase patient trust and that we reduce stigma. And I'm going to share a few quotes from a provider study where we asked people about care before and after Impact, and we looked at interprofessional providers who work in the hospital. And one of the nurse managers described caring for people with substance use disorder before Impact was very emotionally draining and very time-consuming. And what we learned is that Impact alleviated widespread provider moral distress. And another nurse said, I think you feel more empowered when you've got the right medication, the knowledge, and you feel like you have the resources. You actually feel like you're making a difference. And what we've seen is that by introducing addictions care in the hospital, that we're really starting to shift mindsets. And this is so important, partly because hospitals, I think, historically have been such traumatizing places, and I think they really continue to be traumatizing places for people with use disorders, many of whom have experienced trauma in institutions such as jails or bad healthcare experiences. And also because it's a training site where we're training nurses and doctors and social workers and pharmacists and others. And so these are some quotes from this study. As one participant described, when it's somebody in a white coat with expertise who's talking to another doctor, it really can shift mindsets in an amazing way. And another provider described, Impact legitimized the fact that this is an actual disease that we need to treat, and a failure to treat it is a failure to be a good doctor. So given our experience developing and implementing Impact at OHSU, we've moved on to spreading Impact. And I'm going to talk a little bit about how we're doing that. This is a slide that just shows some of the places and ways we're doing that. So certainly through popular media, through developing a toolkit. I've had the opportunity to speak at the National Academy of Sciences. And there's many, many other people nationally that are starting to work on this too, which is really promising. We published a toolkit in the Journal of Addiction Medicine, and I'm happy to share that toolkit if anybody is interested. But the toolkit really is a detailed description of the team and what we do, and also includes a lot of the tools that we use, including some of the work we do around safety care plans with patients who might have active use in the hospital, some of our medication approaches, a whole bunch of resources in there. And I should just add actually here that, I think thinking about addiction medicine consult services at an academic medical center is really important. And I also don't think that this is the only way to do this, and not every hospital is going to have the resources or necessarily the need for a consult service. And so again, I think our goal is to develop this so that we can meet the needs of people at a whole variety of hospitals. So along those lines, what we've been doing for the last year, and we just completed our third cohort, is we're delivering a substance use disorder and hospital care echo. And echo, folks may or may not be familiar with, but echo is a distance education model that connects specialists with remote providers. Echo was actually developed in New Mexico, which is like Oregon, a large rural state with a single academic medical center. And it was initially created around expanding access to hepatitis C treatment. And echo is now used for a whole variety of chronic conditions. So we have, with our substance use disorder and hospital care echo, interprofessional faculty and participants, and it's a 12-week echo series where we combine participant cases, presentations, and didactics. And in this image you can see this is the faculty is up top. I'm sort of sitting at the head of the table there. And then we have folks from around the state who video conference in. And this is a map of the participants from our first two cohorts. We've actually had 140 people from around the state. And we've had, I believe, 33 different hospitals, including frontier hospitals and rural hospitals. So it's been really exciting to do this work. So I'm going to just share a couple of lessons learned and implications, and then again, I'm really happy to open it up to questions. I think in terms of our lessons, the first thing is that hospitals can and should address substance use disorder. So we know that impact increases substance use disorder treatment engagement among non-treatment seeking hospitalized adults. And we also know from some of our research that, that hospitalization can engage particularly high-risk people. So we did a study looking at people who impact saw, who had an opioid use disorder and or an alcohol use disorder. And what we found was that, this was somewhat surprising, that people who were experiencing homelessness or that who had a partner with substance use had an increased odds of initiating medication for opioid use disorder or alcohol use disorder. And I think what this speaks to is that there are people who may want treatment, but because of their social vulnerability, because of some of the chaos that they may be experiencing, that it's either not until, and this really mirrors the qualitative work that we did that showed that both the fear of death was highly motivating for folks, and that also that hospitalization can really be a quote wake-up call and interrupt people's drug use. So again, I think that may be the case broadly, but what we're seeing is that in particular, folks experiencing homelessness or who have a partner with a use disorder, that hospitalization may be a particularly important time to engage them. And then certainly also we work with folks who are extremely medically complex. I'm on service right now, and I can certainly attest to this. The next, and actually the one last thing I want to say is that I think these findings about, going back, sorry, to the why hospitals should do this, is that I think that hospitals need to be part of a health system strategy to engage people with substance use disorders, because there are many folks who are not engaging in ambulatory settings but might engage in a hospital or an ED. Next lesson learned is that broad stakeholder engagement is critical to success. So in our case, external stakeholders informed our intervention. It was through that needs assessment and through meetings with community partners where we were able to develop treatment pathways, identify what those pathways needed to include, and as I mentioned before, that there was an awareness that we needed to incorporate peers as part of our team, or that we wanted to incorporate peers as part of our team. And my advice to others thinking about this work is that it's important to understand the local hospital environment and to identify clinical and executive leadership champions. And, and Kelsey Priest, who's a MD PhD student at OHSU, just led some work in the JSAT that we published in the last month, getting at some of these issues in more detail. In my experience, some of these clinical and executive leadership champions are maybe not who one might expect, but over time they emerge. And so I think talking broadly with folks about the problem and sharing a patient narrative, if folks have access to that or experience with patients, is so important. And then also sharing the business and the quality case. The third lesson is really the importance of having space and a focus for harm reduction. So, in our study, 39% of people engaged in addictions treatment after hospital discharge, 61% did not. It's possible that 39% underestimated the treatment engagement for a variety of reasons, but regardless, a significant portion of people did not. And again, folks may know this, but in case people are not familiar, I do want to just describe what do I mean by harm reduction. So harm reduction is a set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. And many times we hear that harm reduction means meeting people where they're at. I think harm reduction also means honoring people as experts in their own experience. And in hospitals, a lot of the time what it means is moving away from a lot of the paternalistic decision-making and paternalistic approaches that we have that really are shaming and stigmatizing to people with use disorders. So I assert that harm reduction in hospitals is necessary, and also that it can be extremely challenging, and I am speaking from personal experience here. This, quote, culture clash is a term that's described in a paper by Heller and colleagues, and I've put the citation here. I highly recommend anybody interested in this read that paper. It's a paper from 2004. I know the senior author and sent her a text message after I read it, because for me this was just so clearly described, this tension. But there is a tension, and the tension, I think, is between hospitals, which fully embrace a medical model, and a harm reduction philosophy. And I also think that hospitals have a lot to gain from a harm reduction philosophy and integrating those principles, but I don't think it's an easy journey. Some of the things that I think we can do around harm reduction from the hospital include naloxone prescribing, which I think for anybody with an opioid use disorder, and increasingly we're providing folks with methamphetamine use disorders naloxone because there can be fentanyl contamination. Counseling people regarding safer use practices, so asking folks not only do they want to stop using, but assuming that if they are going to continue to use, what are the safe ways that they can use? How can they access syringe exchange? Can they, if they're getting recurrent abscesses from muscling, maybe they can smoke. Maybe there's other ways of using. What's their clean water source? Are they using with other people around overdose prevention, et cetera, et cetera. It's also really important to test and treat infectious diseases. There's a goal nationally around hepatitis C eradication. We're actually starting to explore referral and treatment to hepatitis C at OHSU with some partners from Central City Concern. And then thinking about linkage to low barrier care, including medication for opioid use disorder after discharge. The fourth lesson that I think is really important to underscore is that it's not just opioids. Nationally, as everyone knows, there's been a really strong emphasis on addressing the quote opioid crisis, but really, our data around rates of polysubstance use and also rates of hospitalization related to methamphetamine really support that this is more than opioids. And if we have a blind spot to methamphetamine, we're missing important opportunities. And then next, I think that it's so important to acknowledge that change begins with connection. And I'm quoting one of the peers who's an impact peer and also part of the ECHO faculty, who speaks truth so often, but often says this. And in our experience, peers are quote, a secret weapon. I hate to weaponize peers. This is a quote from some of our qualitative work, but they really are the secret sauce or the secret weapon in hospital care. And peers can serve as cultural brokers. They can help transfer trust to providers and to systems. And with impact, peers are very much not only at the table, but have a voice at the table as we develop the work and develop programs. We've also found that hospitals present unique challenges for peers and that integrating peers into hospital care can be very challenging. We wrote a guideline for other hospital systems interested in integrating peers, sharing some of our lessons learned, and published this in the Substance Abuse Journal in 2000, just this last year. And again, we kind of go through this in much more detail in the paper, but what we found and recommend is that peer programs benefit from having a home base. So having a peer working in a hospital without a team, it doesn't necessarily have to be an impact team, but having some kind of home base grounded in the hospital is really important, and then also support in the community. We recommend having allies and a process for hiring that includes, so for OHSU, we've actually contracted with Mental Health Association oh man, MHAAO, I'm screwing up the acronym, sorry. But we've partnered with MHAAO to contract with for our peers services. But regardless of the sort of contracting and structuring, having a process for hiring, and again, identifying champions is so important. We think it's really important to identify peers who are likely to succeed in the role. And so for the term treatment agnostic is something that we've sort of described. And I think what I mean by this is peers that are able to embrace strategies around harm reduction, that are able to embrace medication treatment, and really the gamut. So regardless of what their own path to recovery was, that they can support people along an array of paths. It's really important for peers to have initial and ongoing training, to have regular, meaningful supervision, and to identify sustainable funding sources. This is a quote from some of the qualitative work we did around having peers as part of the hospital, and one of our impact physicians said, this is an institution, and so often I feel like the peers will show us the ways in which institutions can either harm patients or not hear patients. Those are the conflicts that our patients also experience. We just don't have to see it when we're the ones with the power. Again, I think this is really important in terms of the transformative potential of bringing voice to people with use disorders and in recovery as part of hospital care. So, kind of towards closing, I think that there's a lot of questions about how do we move forward in hospitals. I've had the privilege of working with hospitals across the state and also across the country. And I think I encourage all hospitals to support harm reduction and really think about ways in which they are kind of grounding work and in a harm reduction philosophy. And I believe that abstinence should not be a precondition for help. There is ample data to support that harm reduction saves lives. But thinking about that at a systems level, I think, is really important. I encourage hospitals to include voices of people who use drugs and people in recovery, and to support recovery-oriented systems of care. Where do we need to go? My long-term goal is to change the standard of care such that all hospitals deliver hospital-based addictions care. And I guess one thing I'm realizing I should have put on my last slide is that all hospitals can and should prescribe medication for opioid use disorder and prescribe naloxone. I think that that's sort of not negotiable and should be policy. But how do we get there in terms of changing the standard of care? So I think this depends on broad provider education. It depends on efforts to address individual and structural stigma. It depends on interprofessional teams, diverse internal and external stakeholder champions, policy changes, and research. And also this past year, we published a call to action for hospitalists, where we outline from the perspective of individual hospitalists, hospitalist leaders, and then hospital organizations, how might they start to move forward and do better. I know a number of folks here are from the Pacific Northwest and from Oregon. Our ECHO is open to interprofessional Oregon providers, and I wanted to put the link on here. We also have, in addition to the substance use disorder and hospital ECHO, there are actually a number of other ECHOs that the OHSU section of addiction medicine puts on around addictions care, including ambulatory care, persistent pain and opioids. There's an effective systems for treating addiction in primary care, and also now a hepatitis C and substance use disorder ECHO. And I know our hospital ECHO is open for registration to start January 8th. I'm not sure about the other ones, but anybody can hop on that website. And then I just want to say thank you. I want to acknowledge my team. This is a photo from, it's a little bit outdated, but this is our crew. And with that, I'll be happy to take any questions. Thank you so much for the opportunity to speak.
Thank you, Dr. Englander. That was really interesting. Okay, so if you have any questions, please type them into our chat box. The first one is that, first someone wanted to say amazing life-saving work, exclamation point, 2 of them. Deserve some applause, so applause for you. Thank you so much. And then we had someone who said they were really interested in your impact toolkit that you mentioned. Is that just the article that you had cited on that, or is it?
Yeah, it's an article. It's an article, and also I think it's like a 16-part appendix, and I am happy to send that to you for distribution.
Yeah, that'd be
Yeah, and the other thing I would say is that so we have our impact toolkit. There's also something called, it used to be called Project Shout, and now it's part of the California Bridge Clinic, or excuse me, California Bridge. And I don't know if folks are familiar with that, but my colleague Hannah Snyder at UCSF runs the Project Shout and California Bridge program. And in California, they've really done remarkable things to expand access to medication treatment for opioid use disorder across many, many hospitals and emergency departments. And so that's a wonderful online resource that can be really useful for folks. And I often point folks there. And then the other thing actually is that call to action that we published in the Journal of Hospital Medicine has a table that embedded in it has a bunch of resources. So yeah, I'm happy to share anything that I haven't already.
That would be great. If you wanted to just send that to me, I could send it out to everyone who was on the webinar today. If that
Perfect. I'd love to.
Okay, great. Next question is, what accounts for the higher rates of hospitalization in Oregon and Washington? Is it that they have the means to treat OUD now as opposed to other hospitals that don't necessarily have the means? And what are your recommendations for rural hospitals that might not have that same capacity?
So let's see, I'm just going to go back to that slide. It's actually not that Oregon and Washington have higher rates of hospitalization, but actually that the rate of change, they have higher rising rates. I don't know that it really matters to show this, but I'm doing it anyway. Okay. So basically this is the rate of change. So it's so basically what we're seeing, and I don't really know why this is, I think some of it may be related to stimulant use, and that we're seeing lots of co-use between opioids and stimulants, and we know that the West Coast is hit really hard. I think it also may be a reflection of limited treatment access in community settings. So I don't really have a sort of a research-based answer to that question. It's a good question. I do want to be clear that these are hospitalizations for general medical and general surgical conditions. They're not it's not that people are coming in saying, I need to detox off of opioids and getting admitted. It's that people are coming in with abscesses or endocarditis or, sort of fill in the blank of the medical complications of use disorders, complications from Hep C, et cetera.
Interesting. Okay, next question. Can you send some information or discuss why the medically enhanced residential treatment model failed?
Yes, I would love to. I can do both. We published a paper on that I will describe it with better memory than it's been a couple of years, but I can talk about what happened. So the idea was that folks are sitting in the hospital often for 6, 8, 10 weeks getting IV antibiotics. And these are really difficult hospitalizations for patients to tolerate. And I showed you that figure looking at length of stay expected versus actual, and these are extremely costly. And so the thought was, instead of having people kind of lingering in the hospital, why not support them to, and again, with the assumption that it really was their use disorder and not that they needed ongoing acute medical care. So somebody without a use disorder would discharge to home and get home infusion or go to an infusion center every day, but the systems weren't structured to support that. Or a lot of times providers felt like it was too risky. So the thought was, well, let's bring IV antibiotics into residential treatment. And I think it was a good idea, but it failed, and it failed for a number of reasons. So during the study window of about 6 months when we trialed this, I can't remember the exact numbers, but I want to say somewhere around 46 people were potentially eligible, meaning they had a need for long-term IV antibiotics and they had a substance use disorder. And of those, half of the people basically declined. They didn't want to go. or they were, half the people just didn't want to go to residential treatment. And then there was also a number of folks who were too medically fragile and instead needed physical rehab or had ongoing medical needs that precluded them to go. So during that time window, there were only 7 people who actually went to the medically enhanced residential, and of those 7, only 3 actually completed their recommended medical course there. Folks left residential. And what we found, we did a qualitative study to follow up and explore kind of what happened there. And what we found was that residential treatment really wasn't equipped to manage folks with medical complexity. I actually am caring for somebody right now who, it's an ongoing problem. And that there was, patients described a fair amount of discrimination towards medical illness in this intensive behavioral health setting. So I think it highlights, again, the fragmentation of physical and behavioral health and the needs that we have to really improve access and treatment for people who have complex medical and addiction needs. Or I should say who have addiction and other medical needs.
Second part of that question is, do you know what impact or shout model adjustments have been necessary and effective for community and non-academic hospitals?
Yeah, what a great question. So, with our work with community hospitals across Oregon, there's a number of steps that we've been working on. Some of it is provider education and helping providers learn to be more comfortable prescribing methadone, prescribing buprenorphine, helping folks get waivered. Also and it's not just physician or nurse practitioners and PAs, but it's also the nursing staff and pharmacy staff and others. So there's a big component of education. There's also a lot of work around policies. So what we've learned from our ECHO experience is that a lot of hospitals are telling us that either their pharmacists say or their policies say that it's not legal to prescribe methadone in the hospital, or it's not legal to give buprenorphine in the hospital. And that's just false. But policies often don't match evidence, and policies and providers don't always know what's legal. There's a lot of confusion around that. So we've, as part of the ECHO, we give out our opioid use disorder policy from OHSU and say to folks, feel free to use it. You can slap your logo on there, and the more the merrier using this policy, which we rewrote recently. So there are, and then what we see really widespread is that stigma, and I think that stigma both at an interpersonal level but also a structural level. If we had an epidemic, and I often say this, but it's true, more Americans died in 2017 and 2016 from opioid overdoses than the entire Vietnam War. If we had an epidemic of diabetes or heart disease that were killing that many Americans every year, you can be assured that hospitals would be providing treatment for whatever that diabetic or heart failure condition was. And so the absence of teams and providers that are equipped to address addiction in hospitals, I think really is part of the structural stigma that we need to work against. So I'm rambling a little bit now. I hope I answered your question, but there's a lot of work to be done. There's education, there's policy. Anyway, sorry, I think I got on my soapbox a little bit there.
I think that's great. I think most people appreciate that. So
okay. Sorry.
It's okay. Does anyone else have any other questions? I'm going to take us back to the end of the slides here because I have a couple final slides. No more questions from anyone? Oh, we got one more. Yay. How did unfunded patients fit into your care model? That's a great question.
So we work with anybody who's hospitalized, and regardless of funding. We were very fortunate to have funding from OHSU and also from Care Oregon, which is one of the CCOs in the Portland metro area, or one of the Medicaid payers in the metro area, and part of our local CCO. But we'll work with anyone. Funding is a big issue for treatment in the community. Medicare is another big barrier for a lot of access to treatment in the community. But we sort of do our very best and try to help folks access resources for indigent care. When people are hospitalized, because there are such strong incentives, most hospitals have systems in place to enroll people in Medicaid if they're eligible. So it actually was quite rare that because of the Affordable Care Act and access to Medicaid in Oregon, it was quite rare that people didn't have some funding source, but certainly there are individuals who may be unfunded.
Mm-hmm. Interesting.
Yeah.
Another question, how are peers vetted as far as being treatment agnostic before joining the team?
Yeah, we've learned a lot about hiring peers over the years, and that paper with the guideline describes some of that in more detail. But what we do is, we ask them about, we actually in our interview process give sort of sample case scenarios, and we ask them, what do you do if, we give them a scenario about people on methadone or bup, and we also give a scenario of somebody where that's the recommendation and the patient doesn't want it. But we really ask them to sort of talk us through these scenarios, and we listen for explicit or implicit sort of discriminatory biases. And we just ask people also pretty directly, how do you feel about people being on medication? What do you think? And if we hear them saying, well, it's really substituting one drug for another, and I don't, then we say sort of respectfully, that's not how we approach things, and we're not sure you'd be a good fit. So we just talk about it, and we also then give the cases.
Mm-hmm. Interesting.
Yeah.
Okay.
There's one thing actually, I just saw the chat box here. I'm gonna put something in the chat box.
Yeah.
Whoops. Which is this link that I meant to put on my slide. To a piece that's just beautiful, that was written by Kate O'Neill, who is the young woman Madeline Linsemeyer, who passed in Vermont. This was written by her sister just in the last week or two, and it's a really powerful story and worth reading. It's also a reminder to me that if folks are interested, I always sort of chuckle when I say this, but I think Twitter is a really interesting and good space to learn a lot about some of this stuff. Mm-hmm. And so if folks are interested, it's a space that I've learned a lot from.
Okay, well, I'm going to segue from that into next month's webinar, which I'm going to be leading, because it's going to be about how to find valid and reliable information about substance use disorders online. And one of the things I'll be talking about is social media and the wealth of information, especially really personal stories that you can find there. So please join us next month for that webinar if you'd like to learn more about that. And do we have any other questions from anyone? Nope, looks good. Thank you so much, Dr. Englander. That was a really wonderful webinar. Really appreciate it.
My pleasure. Thank you all for attending, and thanks for inviting me.
Yeah. All right. Well, we'll get off a little bit early today. Everyone can go eat some holiday cookies or finish your shopping, whatever you need to do. And we'll see you next month. All right. Have a great day, everyone.
Okay. Bye-bye.
Bye-bye.